Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. No monitoring system should be used as the sole basis for diagnosis or therapy, and they are intended as an adjunct in patient assessment. Reliance on a single monitoring system alone for patient management is not recommended. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on patient safety in procedural sedation. Why should we change our practice? To help answer this question are procedural sedation nurse Linda Erfle, CRNA Brian Berry, and gastroenterologist Dr. Ashish Chawla.
This is probably a good time to point out that, I hear from my colleagues, my nurses, my friends. We've been around a long time doing outpatient colonoscopy and endoscopy, over 40 years, and we've been doing it safely. So why are we needing to add the capnography? Again, comes back to the fact that no one is educated on this, the nurses. Do adverse events really occur?
So I'm going to take this one. And I do think that we far underestimate adverse events for all procedural sedation as physicians, as CRNAs, and as nurses. Unfortunately, unplanned cardiopulmonary events really occur during procedural sedation, and they contribute to our morbidity and mortality. If you just look at GI cases alone, cardiopulmonary events account for 0.6 to 2.1% of events occurring during these procedures. And as, of course, the patients are sicker or the patients are in emergency settings, these risks are actually much higher. And if we actually explore one of our outcomes database, and I like looking at this because the CORI database, or the Clinical Outcomes Research Initiative, kind of highlights what are the risk factors. And it's everything you guys have stated, as the patient increases in age, as they have higher ASA classification, as they have increased obesity, as they have concurrent risk factors like obstructive sleep apnea or higher risk cancers, the risk of complications, namely cardiopulmonary complications, increase.
Wow, I really feel like we underestimate these events. What are the most common cardiopulmonary complications?
Yeah, that's a good question. So when we think of cardiopulmonary events, Linda, I want to focus on some of the data that we've collected, but certainly hypoxemia is number one, and number two is really airway obstruction. So if we look at just some registry tools we used, 39 countries where we collect data on adverse events during sedation, what we find is clearly hypoxemia is number one, and airway obstruction that leads to respiratory depression is number two. And if we go to other departments like emergency room, where the procedures have higher acuity, the patients are even sicker because it's not planned, and we do procedural sedation here, airway obstruction happens in approximately 12.7% of the patients. Now, we do have other events other than just hypoxemia and airway obstruction. They're bradycardia, arrhythmia, hypotension. But when we think of complications, the two common ones, the two most common are, again, hypoxemia and airway obstruction.
Okay, so capnography detects ventilation in sedated patients who are on supplemental O2. The chest wall movement's not reliable, whereas capnography can detect partial and complete. Okay, we have clearly identified the complications. What is capnography, and how does it reduce the incidence of airway obstruction and hypoxemia?
Yeah, capnography is a waveform. So that basically measures ventilation or breathing. So capnogram will detect if patients have, or a waveform can detect whether the patient has partial to complete obstruction, even when chest wall movement is present. If you don't have a good waveform or don't have a waveform at all, you can tell whether the patient is breathing or not breathing. So one of the key things is that a capnography is associated with detecting hypoxemia and actually respiratory compromise well before it happens, as opposed to an oxygen sat monitor. If a patient has oxygen on board and we sedate them and we wait and they stop breathing, the O2 sat monitor can be delayed by 1 to 3 minutes before we even recognize that a respiratory event is occurring. So capnography in this light is actually associated with a 47% estimated reduction in odds of death. This is during inpatient procedures. In outpatient procedures, especially in GI procedures, capnography actually decreases adverse events. So what we notice is over 100 procedures, whether it's EGD or colonoscopy, you notice that with capnography, there's a 55% reduction in adverse risk or adverse event reduction. And there's over a half or 50% reduction in hypoxemia and severe hypoxemia with patients. Again, because we can detect early that a patient is developing hypoxemia or respiratory depression, we can intervene. We can do a chin lift. We can do a jaw thrust. We can stop the medication and try to wake up the patient. We have opportunity to prevent a problem. And that's what capnography allows.
Well said, Dr. Chawla.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.